Good morning, good evening. Welcome, everyone. Thank you for joining us for today's webinar. My name is Niraj Kag, and I'm the Chief Innovation Officer at University Research and serve as Senior Technical Advisor for the USAID-funded TB Care 2 project. As you know, USAID TB Care 2 has been engaged in infection prevention and control issues with USAID funding since the start of the project in 2010. We do appreciate USAID support for ending TB around the globe. Today's webinar will focus on infection prevention and control, protecting health and safety of healthcare workers from TB, COVID, and other respiratory infections. I'll be moderating the session. Just a little housekeeping before we get started. If you have any questions during the webinar, please type them into the question box in your Zoom control panel. I'll bring them up during the presentation, and we'll also have time for questions at the end. We have a very accomplished panel to walk us through major issues around IPC that affects respiratory infections. These include, our first presenter will be Dr. Ed Nodal. He's a professor in the Departments of Medicine and Global Health and Social Medicine at Harvard Medical School. Ed has done tremendous work on transmission of TB, so I would not say a lot more here. Our second panelist is Dr. Carrie Tudor, who's worked in global health for over 20 years on various global health projects throughout Asia and Africa. Her research interests focus on occupational risk factors for TB among healthcare workers and preventing TB in healthcare workers. She's currently working with Ending TB Transmission Initiative. The next panelist is Dr. Paul Jensen. He's been with CDC, the U.S. Centers for Disease Control and Prevention, for over 30 years and has been involved with TB, IPC, and lab biosafety internationally. He's collaborated with many ministries of health, NGOs, and as well as WHO in implementation, training, and evaluation of IPC and lab biosafety measures. Our next panelist is Dr. Grigory Volchanakov. He currently serves as the Ending TB Transmission Initiative's Vice Chair. He's a specialist in TB control and TB infection control. He serves as the head doctor at Vladimir TB Control Center since 2002. The next one is Dr. Sevim Amdov. He's the Senior Technical Advisor at USAID. He oversees TB and TB HIV programs in a large number of countries. Our final panelist is Dr. Hala Jassim Al-Musawi, who's a public health specialist. Over the past decade, she has worked extensively on TB, TB, HIV, and emerging infectious diseases. She currently serves as the Vice President and oversees at URC and oversees a large portfolio of public health projects in various regions of the world. So now, without further ado, we'll turn the presentation to our first panelist, Dr. Ed Nodal. So Ed, please take it from here.
Thanks very much, Niraj, and welcome all. It's an impressive number of people who have joined us from all over the world, I presume. As Niraj says, and Niraj, can you put up my first slide? Are you able to do that?
Yes, sure.
So, as Niraj said, I'm really a specialist I'm a pulmonologist and a specialist in tuberculosis and have focused on tuberculosis transmission. And today I'd like to talk about transmission of tuberculosis only as a way to talk also about transmission of the COVID virus. Now, I've been fortunate not to have been infected with tuberculosis in my long career, but I have to tell you that I actually have been infected with COVID-19, and I've now really fully recovered from what was a fairly mild case. So I'm not sure I should be here telling you how not to get infected or how not to get other people infected, because I didn't do such a good job. But it has made me very quite interested, of course, as if we needed an excuse in this problem of COVID-19. And we'll be talking about mostly COVID-19, but I will begin with talking about how microorganisms get from one person to another. And I have really just one slide, and we'll just talk about these things in general, and our co-panelists, Paul Gregory, Kari Hala, and I'm forgetting somebody, will jump in on a variety of these issues in about 20 minutes when I'm done here. So first of all, let's just talk about tuberculosis transmission, because in many ways it's much simpler than and better known than our understanding of virus transmission in general and COVID-19 in particular. Tuberculosis is, I think you probably all know, pretty much an exclusively airborne infection. It isn't spread by touching, by eating, by sexual contact, by vectors, by and large, although some animals can be intermediary hosts for tuberculosis. It's spread by the airborne route. And there are two main reasons why TB is such a exclusively airborne infection. The first one is that the target of the tuberculous bacillus is very deep in the lung, in the alveolar macrophage. That's where the tuberculosis bacillus is ingested, replicates, and begins a sustained infection if that's going to happen. That's very deep in the lung. So if TB is released from a patient with active tuberculosis by coughing or sneezing, large particles containing tuberculosis are released, and they contaminate surfaces, as we're going to talk about with COVID-19. And people touch them, and they touch their eyes, nose, and mouth, but they don't get tuberculosis that way, or at least it would be extraordinarily rare. What happens is that some of the particles that, before they reach the ground and by falling, evaporate into what are called droplet nuclei, the dried residual material of a larger respiratory droplet. And once they get small enough, they stop falling and they begin to basically float on air currents that occur particularly indoors in occupied buildings. So people's motion, people's heat, body heat, all generate currents which keep lots of things floating around in the air. And if you inhale a very small particle, you can get tuberculosis. Now that's the second reason why tuberculosis is airborne, because airborne infections, the droplets get diluted in room air quite substantially, although if you're very close to the source, they haven't had time to be diluted. But generally speaking, they get diluted in room air. And so what's remarkable about tuberculosis and other airborne infections, and there aren't too many, is that it is infectious enough that inhaling just a very low dose is enough to cause infection. In fact, in some animal models, like the guinea pig, it's been taught for many years that just inhaling one infectious droplet is sufficient to cause tuberculosis. And in human children, and adults, but in children in particular, who are contacts of active cases, if they are investigated and found to be, sick or test positive after a index case in the household has tuberculosis, if an X-ray is done, often there is one single focus of infection in the periphery of the lung, often in the lower lobes where most of the air goes. So there's a lot of evidence for tuberculosis that a very low dose, perhaps a single infectious droplet, can cause tuberculosis. So two reasons. Very small particles have to get out to the periphery of the lung. And number two, very low doses of infection can do it. Now, what about influenza, SARS, and now COVID-19? Well, that story is a lot less clear. And indeed, it's probably true that there are multiple modes of infection. What's commonly taught is that influenza, SARS in that brief period when it was occurring in Asia and in Canada and a few other places, is spread by large droplets. The larger particles that are generated when you speak, when you cough, and even with quiet breathing, as alveoli pop open, aerosol is generated that can be exhaled. And what's commonly taught is that those large particles either can project directly into someone else's eyes, nose, or mouth, or face, and thereby get to a mucosal membrane and cause a viral infection. That's what's being taught about COVID-19. The official WHO position and a variety of other authoritative sources say COVID-19 is spread by contact, either direct contact, you are close to someone who is speaking and or singing, and aerosol is generated, you get hit by some of these particles, or indirectly, where these particles are showering their environment in the immediate vicinity. We talk about a meter, and now we're talking about 2 meters, essentially 6 feet as it's used in the U.S., and as a range where these large droplets settle out. And the indirect mode is that you touch these contaminated surfaces and then touch your eyes, nose, or mouth and end up with a viral infection. So unlike tuberculosis, number one, the particles that are thought to cause transmission are thought to be large respiratory droplets. And secondly, it doesn't have to get all the way down to the alveolus of the lung. It can cause infection in mucosal membranes in various places in the body, eyes, nose, mouth. You can ingest COVID-19 and have initially a gastrointestinal infection, which actually we'll talk about in a minute, is probably, quotes, a safer way to be infected, so to speak, because the lung is involved, if it's involved at all, later and less severely. So now so as you know, the recommendations for avoiding infection with COVID-19 have all to do with hand washing and to keep your hands off your face. Very recently in the US, based on a report from the Academy of Medicine to the White House, there has been a suggestion that a great deal of transmission of COVID-19 occurs from persons who are asymptomatic but carrying, colonized in their nasopharynx with the virus, and that in speaking, they unknowingly can transmit the infection. Now that's actually a common factor with tuberculosis as well, to the extent that unsuspected cases of tuberculosis in hospitals, in clinics, in the community also account for a lot of transmission. But with COVID-19, there is you don't even have to be coughing or sneezing, apparently. You can generate viral aerosol simply by talking and or breathing. So that's one of the reasons why it's been suggested that otherwise healthy people who still yet may be colonized with COVID-19 begin to wear a face covering, not even a mask, because surgical mask, because there is a great concern that we would deprive healthcare workers of a limited supply of respirators and also a surgical mask. So the recommendation is for cloth, homemade bandanas and things like that. How effective they are, we can talk about in the discussion. There's reason to believe that they might be somewhat effective. Among other things, and this was been true of a number of outbreaks, wearing a surgical mask or a bandana is a reminder not to touch your eyes, nose, and mouth. And as you know, in many Asian countries, this is commonly practiced as a form of hygiene, and it's just not universally done. But now it's becoming quite common. So I think I've talked about number one and number two, and well, on number two, is there evidence that COVID-19 can also be transmitted by the airborne route? And I would say that I think there is evidence. First of all, if large particles contain virus, small particles absolutely have to contain virus. And studies of room sampling in Indiana and other places have shown, using PCR methods, that you can find virus in the air. You can find virus on surfaces we know. And if it is in the air, there's certainly the potential that it could cause transmission. Now, it's really often difficult to know when someone gets infected whether they got infected by large droplets or small droplets. Occasionally, there are events that happen, transmission events that happen, where it's clear that there was no person-to-person contact and that the only contact was through the air. With SARS, for example, in Hong Kong, there was an apartment building where there was some faulty plumbing, and people throughout many floors of the building with no person-to-person contact became infected. And it turns out that these viruses, including COVID-19, also pass through the gastrointestinal tract and can be aerosolized through defecation and therefore, and through the flushing of toilets, etc. An aerosol was generated in that building, which was thought to be the source of transmission. So that's airborne transmission, albeit not directly person from person, but it was evidence, clear evidence of transmission. There's actually a similar event in Hong Kong. I don't know what it says about plumbing standards in Hong Kong, but there's a similar apartment building where there's been transmission between floors and thought again to be due to a faulty plumbing system of COVID-19. So there is some direct evidence that suggests that. There have been episodes on airplanes where people are sitting far apart, have had no direct contact that anyone can actually document, and where transmission has occurred with SARS. And I suspect, except that no one is flying, that there may be similar episodes that will occur. The other final suggestive evidence of concern about airborne infection, in my mind, is the recommendation that healthcare workers wear fit-tested respirators and not surgical masks. As you all know, respirators, as opposed to masks, are tight-fitting face coverings that fit closely around the nose and seal, hopefully, around the face, and are tested with in a number of ways to be sure that they do fit tightly and there's no leaks around the seal. And these are recommended for protection against airborne infection. And CDC and other agencies have been very clear that healthcare workers should be wearing respirators, and that has, of course, generated a huge demand for N95 and equivalent respirators around the world, and for their reuse. And all of that, to me, suggests that there is, at the highest levels, some concern about airborne spread, despite the facts that WHO medical authorities get on television and say this is spread by contact. The other thing is that there have been episodes of quite extensive spread of SARS, of COVID-19. For example, there was a choir practice 2.5 hours long in Seattle, state of Washington, or in the state of Washington rather, it wasn't Seattle, where 40-some of 60, approximately 40 of 60 choir members during that 45-minute, 2.5-hour practice, where of course people are singing and generating aerosol, became sick, most of whom were tested positive with COVID, and 2 actually have died. So again, a situation where it's a little hard to imagine that everyone had direct contact with each other in the usual sense, or with large particles. Although, again, probably multi-mode transmission, large particles, small particles, direct contact with particles, and indirect contact with particles. So finally, in the last couple of minutes, I'd like to talk about control strategies. And again, there are some parallels with tuberculosis. We tend to isolate patients with tuberculosis, at least until we get them started on effective therapy. We don't have an effective therapy for COVID-19, so that isolation tends to be longer, and it's often self-isolation at home. And then in the hospital, of course, people are practicing isolation for contact precautions, and if possible, it's recommended also that airborne precautions be practiced. So again, some concerned about that. What about air disinfection? Well, that's something I've devoted a great deal of my life to studying, the ways to disinfect the air. And for most places in the world, natural ventilation, open windows, is the main way that that is accomplished. And is highly effective when conditions are ideal outside. You have good airflow, you have a building that's designed for it. But very often we see in many parts of the world, for example, clinics where the only rooms with windows are the examining rooms, which is good, on the periphery, and all the patients are waiting in a corridor in the middle of the building, and the doors and windows are closed, and there's really no outside air ventilation. Mechanical ventilation, and we can talk about this in the discussion, is also can be used, but it has a lot of limitations. In hospitals in resource-rich countries, there are isolation rooms, airborne isolation rooms, that are designed for very high rates of flow and can accomplish good isolation by that way. Negative pressure, which just means the direction of the airflow is from the outside into the room rather than the inside of the room out, and that's important for keeping airborne infection contained. And finally, there's germicidal ultraviolet air disinfection. I shouldn't say finally, there's also room air cleaners, which we see used widely around the world, and which I'm sure my colleague Paul Jensen and Grigory Volchenkov will have comments on. When we see these things and we test them, they tend to produce relatively little airflow relative to the large volume of a room, contributing sometimes a fraction of an air change, sometimes an air change, rarely more than that. Whereas the recommendation for controlling airborne infection by dilution is 6 to 12 air changes per hour, which isn't a lot. And that brings me to germicidal UV, upper room germicidal UV. This is the practice of putting specialized fixtures that generate germicidal UV irradiation in the upper room above people's heads. And depending on either convection air mixing or more ideally low velocity ceiling fans, to produce good mixing between the upper and lower room, producing very high rates of air disinfection in the lower room as well. There are at least 2 controlled studies in the literature, one of which I was involved in and Paul was involved in, where we measured an equivalent of adding 24 air changes to the room by virtue of disinfecting the air above people's heads, preventing tuberculosis transmission from patients to very sensitive guinea pigs. And that was done by Rod Iscom, also in Peru, similar, about 80% protection approximately. So I personally think that ultraviolet air disinfection ought to be in use now in many parts of the world where COVID is being treated. It is not likely to stop or completely stop large droplet transmission or even contact transmission, although it may help. But it is an important way of achieving air disinfection and reducing the potential for small droplet spread in the immediate vicinity of the patient, but also further away. So it's a low cost, relatively low cost compared to mechanical ventilation way of disinfecting air. It's quite safe. You do need to know what you're doing, and you have to have good quality fixtures. And we can talk about that in the discussion. And I think at that point, I'll stop. And Niraj, you can tell me whether we're going to have questions now or move on to the panel, and at your disposal.
Thanks, Ed, for this wonderful presentation, and thanks for raising many issues. I know we have very limited time today, but just to sort of put in a plug, we are planning to host a series of webinars on IPC, so we may not be able to answer all the questions because there are many questions that are coming up on the side panel. However, let me move on to the next panelist, Paul Jensen from the Centers of Disease, U.S. Centers for Disease Control. Paul, we have a question for you. What have we learned from our fight to end TB that could be a boon to protect healthcare workers from COVID-19 infection and seasonal influenza?
Okay, thank you, Niraj. Thank you, Ed, for your excellent presentation. And for those that are looking at the screen or have a blank screen, I have no slides because I'm just trying to respond to this question. First off, I think if we take a look at what Ed presented about airborne versus contact or large droplet, we know how to control for TB. We know how to control for influenza or seasonal influenza, which we know is spread by droplets. We know it's spread by small droplets, and there's limited data that it's spread by the airborne route. So when we're talking about COVID-19, we're just going to throw the whole package of infection control measures. So when we're talking about TB, we're focusing mainly on the airborne. When we're talking about influenza or the COVID-19, we have to do good infection control practices and maybe go beyond what might be the average standard precautions or general infection control measures. So when we're talking about the TB aspects or the airborne aspects of infection control, Ed summarized them very well. The only comments that I would like to add to his relate to the ventilation side of things. From the ventilation side of things, there's some areas of the world, actually quite a few areas of the world, where natural ventilation is acceptable, and natural ventilation for the airborne component would be perfectly acceptable. And when we're talking about the natural ventilation, we want that natural ventilation 24/7. And the second comment relates to room air cleaners. All of us have seen room air cleaners. All of us have heard the sales pitches of room air cleaners. And I just want to make one caveat to Ed's comment, and that's two-pronged. One is there are a few and very few air cleaners that can provide the air exchange. There are a few and very few where you can exhaust that air to the outside and provide negative pressure containment. So in general, room air cleaners are junk. But I don't want to throw the baby out with the bathwater, to use slang, but there may be a few instances in which it could be used. Thank you.
Thanks, Paul. Our next panelist will respond to this question. So this is for Gregory. Gregory, what are the key strategies to ensure effective infection prevention and control, administrative controls to combat infectious diseases?
Yeah, thanks for your question. I believe everybody understands that administrative controls is the basis for effective prevention of any infection. And putting order into our interventions actually very, very essential. We can use very expensive systems, extremely expensive respirators and so on. But without education, without good organization of our preventive program, we cannot achieve the goal. So there are several components of administrative control programs, and most important is education. Educational activities are most precious, most important part. So everybody involved into the care of infectious diseases, including TB or COVID-19, should understand the risks, should understand the basics of transmission, and should understand the hierarchy of controls, which is aimed to reduce the risk for everybody, for patient, visitor, and for healthcare worker. So the administrative controls should be based on risk assessment of the facility, of the setting we work in. Based on the risk assessment, we should print a plan of the interventions, and it's essential to develop the zoning of the facility and to divide the facility into the low, medium, and high risk zoning, and to put signage. So everybody should understand that some restricted areas, some are low risk areas for rest without PPE, and flows should be organized in safe way in the facility. The personal respiratory protection program should be organized well. It's not enough to just distribute respirators or masks. We should educate people, we should organize their distribution, we should organize their fit testing, disposal, safe use, and reuse. Reuse is essential in this COVID disaster, which is now happening. And we unfortunately have to reuse for a long time PRP in safe way. It can be done, but it needs to be organized well. Any kind of environmental control should be organized well. Huge resource, like Paul Jensen just said, natural ventilation, 24/7. Huge amount ACH can be achieved in safe way, free of charge, extremely safe, and actually life-saving resource. But it should be organized. Everybody should understand how to do it, who is responsible, how to monitor. Upper room UVGI cannot be done without organizational issues. The basic principles of effective strategies, I believe, is most important to understand the risk, to understand the transmission of the pathogen. And there are still many unknowns about COVID-19. It's quite clear about TB now, about transmission, I mean. But we do understand there are airborne transmission, contact transmission, droplet transmission. There are certain measures to prevent everything. The second is sustainability of our intervention. Now the world became the low resource settings, very, very low resource settings in Florida, in China, in Myanmar, in Russia. So we have to prioritize using our resources. We have to, unfortunately, reuse some disposal things, and it can be organized in a safe way. There are recommendations on that. The next is comprehensive approach. We should not think only about respirators, for example, or about upper room UVGI. We should think about all staff, all procedures, all patients, all flows, and based on the risk assessment and prioritization, build the comprehensive and sustainable program. Monitoring and evaluation of our work is also very important. I see that several questions about respiratory reuse and so on. Hope we'll have time in future sessions to discuss all these important issues. Thank you.
Thanks, Gregory. Our next panelist is Dr. Carrie Tudor. Shar, can you just put the slide from Carrie? Carrie is, as I introduced her, from ETTI, but also from the International Council of Nurses. So, Carrie.
Thank you, and I just have the slide here more for so that I can remember all of the things that I want to say. And to all the nurses out there, hello, I see there are several nurses online. So to touch on what I think Ed and Paul and Grigori have touched on a lot of this already. The role of the national programs is to ensure that healthcare workers are safe when they go to work. We know that healthcare workers are at a greater risk of developing TB, but that goes for COVID-19 as well. I know in some countries, Spain and Italy, they're estimating that 14% of all the cases are in healthcare workers, 14% and 10% respectively. Unfortunately, there's not been a very good surveillance system in place or one universal place where all of these cases among healthcare workers are being counted. So it is happening, and we know that it happens with TB. So any infection control program at the national level, it shouldn't be just a TB infection control program. And as we're seeing with COVID-19, it's really airborne contact, droplet precautions. So ideally, the TB program should be collaborating at the national level across different departments to ensure that there's a national infection control program, and that airborne infection control, if there's this already exists in most countries, but to make sure that airborne gets added into that. We find in countries that TB infection control, which is really airborne infection control, is usually separate from a general infection control program, and you go through hospitals and the infection control team is not really focused on airborne infection control. So it should really be a collaborative effort, and airborne needs to be included in any national or facility infection control plan. It really comes down to, I think Grigori mentioned a lot of this, but there has to be a work plan and there has to be a budget. And in most settings, we find that there's just a general hospital budget or a general program budget without a separate line item for infection control. And so there's no money to buy respirators, there's no money to buy other equipment like GUV fixtures or whatever it might be. So there needs to be somehow a budget, including the personnel. It's going to need people to do that. People need to be trained. And surveillance is another really important part of what the national programs can do to protect healthcare workers. If we are tracking the number of cases, then we can react to what's working and what's not working in terms of protecting healthcare workers at the facility level. Thank you.
Okay, Terry, this takes us to, I think Dr. Salim Ahmedov has not been able to join us. He had some other meetings, but I'll go ask the final question to Dr. Hala Jassim Al-Musawi. So Hala, how can we leverage existing TB-related IPC infrastructure and interventions to combat emerging infectious diseases such as COVID-19?
Thank you very much for the question, and hi everyone. I just put together very quickly a slide for the response to this question. If you can put this slide on, if not, I can proceed. So yes, so as we all know that the coronavirus now pandemic sweeps this world, and we all, the TB community as well as public health specialists, we are worried about TB programs, we are worried about patients, we are worried about healthcare providers. As low-income countries report COVID-19 infections, there are urgent concerns of whether health systems will be able to respond, and specifically whether the health workers will be protected at the front lines of diagnosing and treating infecting patients. WHO, the World Health Organization, as well as USAID recently released guidance documents to implementing partners, to national TB programs, health personnel, to urgently maintain continuity of essential services, including TB, and for people affected with TB during COVID-19 pandemic. And also a clear guidance on maximizing the joint support to tackle both diseases. So in the guidance, WHO emphasize the critical, it's very important. It's very critical to slow the spread and transmission of the infection, as Ed and others mentioned, and also to stress that isolation, testing, and tracing comprise the backbone of the response. With the recently released published guidance, IPC guidance for COVID-19, that clearly describes the standard airborne IPC practices for hospital settings. And we can see that most of these mirror the general WHO minimum requirements for IPC programs, including triage and administrative controls, environmental and engineering controls, personal protective equipment. These are standard airborne IPC practices for which there is existing infrastructure in the form of guidance, protocols, trained healthcare workers in many countries that we could leverage these existing platforms and infrastructure, the awareness to most effectively address the nosocomial COVID-19 infection. Specifically, with regard to the figure that I just put together quickly just while we are having this webinar, all measures should be in place to ensure continuity of TB services while responding to the pandemic. So for prevention, of course, ensuring that all measures are taken to limit the transmission of TB and COVID in congregate settings. Also, mode of transmission of these diseases are slightly different. Administrative, environmental, personal protective measures, including basic infection prevention and control, triage, apply to both. Provision of prevention measures, TB prevention treatment remain a priority. With regard to diagnosis, accurate diagnosis, of course, the tests are critical for both, and the tests for two conditions are different. We understand, we all know that TB lab networks have been established in many countries with support of WHO, USAID, and many international donors and partners. These networks, as well as specimen transport mechanisms, could also be used for COVID diagnosis and surveillance. With regard to treatment and care, TB program staff, with their experience, capacity, including their capacity in active case finding, contact tracing, as well placed to share knowledge and expertise, provide technical as well as logistical support, provide opportunities to support the response or the joint response to COVID-19. Same thing with digital health technologies. So many digital health technologies designed to support TB response can be intensified to support COVID response as well, through improved communication, counseling, care, and information management, among other benefits. I joined a very interesting webinar for World Bank, where they did mention that recently, like every day, they receive, or WHO also receive, a huge number of these technologies to address COVID-19. When we reviewed most of these technologies, kind of similar to the technologies introduced to support TB. With regard to procurement, supply, and risk management, of course, planning, monitoring are very essential to ensure procurement and supply of medicines. And there is infrastructure for this, for TB. And USAID, as well as many other donors, play an essential role in supporting countries to secure adequate and sustainable supplies of TB medicines, drugs, and diagnostic. Countries also, per recent WHO guidance, also advised countries to place their orders for 2020 delivery as soon as possible, given the anticipated delays in transport and delivery mechanisms. With regard to human resource, I will combine 2 points here: human resource and capacity building. So respiratory physicians, nurses, pulmonary staff of all grades, TB specialists, healthcare workers at primary healthcare level, they received a lot of training, mentoring, and maybe points of reference for patients with pulmonary complications of COVID. They can also learn more about the current WHO recommendations for supportive treatment and containment of COVID-19. The response to COVID-19 could also benefit from the capacity building efforts developed for TB over many years of investment by WHO, CDC, USAID, national authorities, as well as other implementing partners. And these capacity building initiatives include infection prevention and control, contact tracing, household and community-based care, surveillance, and monitoring systems. So there are many best practices, lessons to share, experiences and approaches, as well as tools and technologies that we can apply, that we are currently using to NTB, and we can apply to assist with the response to COVID-19, such as infection prevention, artificial intelligence, technologies with using X-ray, contact tracing, telemedicine, and psychosocial support. Thank you so much.
Thank you, Hala. So I'm going to go now to the audience. We have first question, which was sent to us in an email. So this is addressed to Dr. Nadel. Is there, if there are many pieces of evidence or important concerns about the airborne transmission, even not totally connected with WHO recommendations in regarding of healthcare workers wearing a surgical mask during assistance inside hospitals, inside wards, with only air conditioned, with no barriers, HEPA filter, UV light, should the facility recommend the N95 or FFP2 to those healthcare workers?
Well, I don't know what other countries are recommending. I know in this country, in the US, CDC is recommending N95 respirators for healthcare workers treating patients. And I believe the reason is because of concern of airborne spread. I think that same recommendation applies around the world, but we realize that N95 respirators are much more expensive, that fit testing, although quite doable under normal conditions, is quite challenging in the middle of a pandemic. To do it properly, and Paul and Grigory are quite expert in this arena, one should have a variety of respirators to choose from, that if one doesn't fit properly, you can choose another one of a different size, of a different make. And right now, with a shortage of any kind of respiratory protection, you know, it's doubtful that ideal fit testing is available. But still, I would think that if one can get a respirator which is designed to keep out airborne particles, that your chance of getting infected is lower than if you use a surgical mask, and that's better than using probably a cloth face cover, and that's better than using nothing. Paul?
Yeah, I think that's a great answer. And just to add to that, you know, we have to think about, you know, how is it being spread? We know that a majority of it is droplet. So we really have to go back to what Grigory said, look at administrative control measures. And we also need to look at personal protective equipment. You know, does the person have a simple face shield? If you have a face shield on and the patient coughs, what happens? None of those particles are going to go through that face shield. Some may go around, but again, a fraction is probably airborne transmitted. And we have to think simple also. A face shield doesn't have to be one of these expensive commercial things that, you know, you can move up and down or whatever. It could be a simple piece of plastic on a string around your head. It could be wearing, you know, some kind of glasses or goggles and along with your respirator. And if you do not have respirators, anything is better than nothing. And why do I say that? You know, we know what a respirator is. A respirator is, you know, we use the term N95, which means it meets a US standard. We use the term FFP2, which means it meets a European standard. There are counterfeit respirators out there that instead of 94, 95% effective or efficient, maybe they're 80% efficient. 80% efficiency is much better than zero. A surgical mask or procedure mask, they're designed to, you know, protect the environment, which could be in surgery, the patient, in the patient setting. It could be, if the patient's wearing it, to protect others around them from getting large droplets on them or stopping some of the droplet nuclei or very small droplets from getting out in the air. So we just have to think about, you know, what is feasible and just do the best we can in that situation. Thank you.
We have another question, which is interesting. It's how can we reuse the disposable masks? As the news is coming upon about the COVID, that it just hangs on to the mask. So any responses to that? I know there is some H2O2 coming up and all that. So any of the panelists want to respond to this?
Yeah, this is Paul Jensen, and that kind of follows on to what we just talked about before, the difference between a respirator and a mask. You call it surgical mask or procedure mask. What a lot of places are doing now to protect respirators is wear a loose-fitting surgical mask or a bandana or something on the outside of the respirator. That way, any large droplets will be on that bandana, which can be washed in hot water and soap, or a cloth surgical mask can be washed in hot water or soap, or a disposable surgical mask could be disposed of or thrown out. As far as disinfection of respirators, there's many groups that have been working on it, especially these last couple months. And there's nothing that's perfect. What we found is, UV, especially with the thin rubber band head straps, can degrade those head straps, and then the second or third time, you stretch it and it breaks. Normally, it lasts at least a few more stretches before that thin rubber band breaks. As far as UV on the filter material, it may make the outside a little bit fragile, but it doesn't really affect the filtration efficiency. If you use something like alcohol on an N95 or FFP2 respirator, that alcohol affects the efficiency of the filter. These filters are, the technical term is expanded polypropylene. That just means that, it's some kind of a polymer that when they heat it up, it sort of separates and you get all these little fibers and lines of material. And then they put it across a high voltage to give it a charge. So that N95 or FFP2 respirator, and same thing with some ventilation filters, the efficiency is enhanced because of that charge, but alcohol removes that charge. So a filter could be 50% efficient after washing with alcohol. So what we found so far really is vaporized hydrogen peroxide does not affect straps. It does not affect the filter material, but in a small facility, it's probably not economically feasible. Will there be a cheap, simple vaporized hydrogen peroxide system in the next couple months? Probably not. So the best you can do is protect the respirator, and then when in doubt, throw it out. Thank you.
Thanks, Paul. I think there's an interesting question about if a person is infected with COVID-19, but is also suspect of TB, how do you collect the sputum? So Ed or Paul?
I just responded to that in writing. I think
Okay.
that airborne precautions that are good for TB should be adequate for COVID in an open area, et cetera. But in addition, for COVID, you need to take contact precautions, which are not generally necessary for TB. So it's actually a bit more trickier if you have both suspicion of tuberculosis and COVID. Airborne precautions for both are similar, but for COVID, you need to then also have contact precautions.
And Grigori, do you want to mention what you do in your sputum booths in Russia with the UV?
Sputum collection is aerosol aerosol generating procedure, so it's high risk procedure. So the safest way to do it is outdoors with huge ACH created by natural wind. And if you should work inside the building or the room, the safest way is to create a small space in the room with the negative pressure with high ACH. It's a negative pressure both. So it can be done safely inside it. And again, the procedure is the same. And I would recommend use contact precautions for TB as well as for COVID-19, because we do know that there are contact pathogens like hepatitis virus C, HIV, and so on. So we should be careful. Basically, it's the same. Airborne precautions, contact precautions. And we just discussed the patient with the COVID or TB. So basically the same procedure.
You know, there is some, this is Ed, there is some evidence that one paper that I've seen from China that persons with known tuberculosis or old tuberculosis even actually have worse outcomes with COVID-19. I can think of a couple reasons why that may be. Persons who've had TB have actually more lung injury already than we have sometimes acknowledged. There is an underlying lung damage with tuberculosis, and on top of that, you add COVID-19. In addition, conditions that lead to chronic inflammation, and tuberculosis is one of them, tend to predispose to exaggerated inflammatory reactions to COVID-19, which is the reason that many people end up on respirators and dying with this horrible virus, that it's a so-called cytokine storm. And many chronic inflammatory conditions can predispose to that, and tuberculosis is among them. So I think for those of us who've been engaged with tuberculosis for most of our careers, COVID is a really unfortunate pandemic, in many ways as bad or worse than HIV in terms of its potential for adding to the burden of tuberculosis globally.
Thank you. I think we're coming close to our end of the session. I just want to thank over 500 participants who joined our discussion today. We would be hosting a series of other webinars on infection prevention control in the coming weeks. So also the presentation, today's presentation will be available online. We'll also email link to all the participants. So again, thank you all. I want to thank the panelists as well as all the participants.
I will spend some time, Niraj, going through these questions and typing some answers, if that's okay.
Yeah, I think one question I have is, sorry, Hala, go ahead.
Sorry, Paul wanted us to also share something. I'm not sure if we have this.
Oh, yeah. Sorry. Paul, can you say that this is about the Africa initiative?
Oh, yes, I can, which is an infection control group in Africa, is presenting tomorrow. Sorry, I just closed that email. Is presenting a webinar tomorrow, and what I've emailed the announcement to Niraj and Hala, and if you
we can forward it.
If you forward it to everybody, it's just another opportunity to learn about how people are dealing with the COVID situation. This will be Africa centric, but I think it will be applicable to most everybody in the world. So anyway, everybody is invited. Hopefully there'll be enough bandwidth. I don't know that they were planning for 500 people, but I think the more the merrier.
We'll do that. Now, I have a question for, and I know we're running out of time, which should be of interest to many people from various countries where BCG coverage is very high. So this is to any of the panelists. Do you think BCG vaccination provides any protection to people if they're exposed to COVID-19?
So I can answer that, Niraj. I'm going to be a co-investigator on a study here in Boston, but there's studies in Europe and another one here in Boston as a potential vaccination for healthcare workers. Of course, U.S. workers, by and large, have not had BCG, whereas much of the world has. Anyway, BCG is a potent stimulator of an innate immunity, and it's used for many, many things and has benefits that are well beyond tuberculosis in every study that's ever been done. Its major use in the US is for treating bladder cancer, which is all through innate immunity, bone marrow mediated. So there is some thought that BCG might provide some non-specific protection or modification of COVID-19, and several studies looking at whether it might protect healthcare workers. It's unclear whether people who've already been vaccinated will get additional benefit from revaccination. Personally, I had BCG about 10 years ago, and I'm very happy and fortunate to have had a mild case of COVID-19 as things go. I don't know whether it's related, of course, but I'm kind of happy that I had BCG in case it was a factor. Anyway, it's an interesting idea. It's not proven, but these studies won't take long to do among healthcare workers because the rates of infection are quite high.
Thank you all. So I just want to say thanks for all of participants. As I said, we will be hosting a number of other webinars on infection prevention control, digital health related to COVID/TB in the coming weeks. All of these webinars will be conducted in English, but then also we'll have sessions in French, Spanish, Portuguese in the coming weeks. So we'll keep you guys posted, and please share the links with your colleagues. We think this is an opportunity to put greater emphasis on infection prevention and control. We haven't been very successful in pushing IPC agenda, but this may be the time because everyone is very concerned about COVID, forgetting that TB still infects a lot more people. So while we deal with COVID, let's make sure we continue to push the agenda of IPC globally. Thank you very much. Till we talk again. Bye-bye.
I don't know if this makes it easier for you, but we can download all of the Q&A and send them to all of the attendees over email instead. Or if you'd like to answer them directly right now, that's also very okay.
You want to download them and send them to me?
Sure, I can, yeah, I can download them.
And then
send
can
them
you
to
distribute the answers?
Yes, we can send it to
Okay,
all
let's
of the
do that.
attendees.
That's fine. I can't answer all of these, but I'll answer as many as I can.
Yeah, I think we could maybe split it up between the just to make it easier for you, so you're not
Okay,
just.
you're happy to do that.
All right, thank you very much.
Yeah, I'll just finish this one I'm working on.
Yeah, go for it.